Dear colleagues, dear panelists, my pleasure to participate in this session. My purpose is quite to be close to the case report of Hakim previously, and it concerns the problematic of TAVI and left main as follows. I do not have any conflict of interest to disclose. And this is related to a height 85-year-old patient with a previous history of STEMI and right coronary artery stenting. And he had later right carotid endarterectomy with a past history of prostatic adenocarcinoma. He was referred to our institution because of severe and so symptomatic aortic stenosis. And once the scoring assessment was done, the TAVI team decided to propose to this patient TAVI rather than surgery valve replacement as useful. Once CT analysis performed, we were, and I was so concerned by this very large calcification located on the distal part of the left cusp leaflet. And due to different length between annulus and left main and annulus and the distal part of this cusp, I was afraid because of the risk of acute left main occlusion during TAVI implantation. Nevertheless, we had a long discussion and we decided to try to perform TAVI with special attention to the relationship between the calcification and the left main during TAVI implantation. So we defined this strategy first before using the valve, which was rapid pacing of the patient, to perform a balloon aortic valvuloplasty using an intentionally undersized balloon to know what will happen, to perform an aortic angiogram and to add an attentive analysis of both left main flow and left main patency. So the picture is the following. When the balloon is inflated, you can see this calcified mass moving, go to the left main. And keep in mind that this balloon is very undersized, so this mass goes really close to the left main with, at our interpretation, a very high risk of left main occlusion during TAVI implantation. So we had two solutions. The first one was to perform TAVI and to try to find a solution to avoid this risk of occlusion, and the second one would have been to propose this patient to surgery. So during this procedure, we decided to go on with TAVI solution, and we decided the following strategy. So the idea was to protect the left main of the movement of this calcification to the ostium of the left main using a stent. And as in contrast with Hakim, the idea was to put the stent with a severe protrusion into the sinus of Valsalva to protect the left main. So, and the steps were follows. The first one, to perform a rapid pacing using the valve wire as usual, to use a radial access to perform an aortic angiogram prior to deploy the valve, to perform next left main direct stenting with an intentional protrusion of the stent into the sinus of Valsalva to repress this calcification, then to implant the valve, and following by balloon aortic deflation first and the left main deflation finally. So we advanced the stent into the LAD with a guiding catheter, and we advanced the TAVI through a conventional access. So you can see the valve going to and across his aortic valve. Next movie showed that both stent and TAVI were in correct places. So we decided to go to inflation, and we therefore rapid paced the patient, inflated the stent, inflated the TAVI. You can see either compression or cross of the stent, but it's we had a consent because of the crush of the stent, but the analysis showed that in fact the stent was really patent. We can see on this second movie the calcified mass going to the left main, but due to the stent in the left main, this calcified mass is repressed downside to the left main and outside of the stent of the TAVI, in fact. So we were quite confident because we supposed that this calcification were in the place we aimed to get it at the end of the procedure. We had an attentive analysis, and we performed a control angiogram prior to leave the patient, and we can see the patency of the left main, we can see the valve in good place, and we can see this calcified mass just above the left main and outside of the TAVI. I'd like to thank my proctor for the help to go on our TAVI program, and we can have a short discussion if you agree.
Okay. Then we have two specialists in the room. So Hakim, any comment?
Microphone.
Yeah.
First of all, congratulations, because it was really well done. A little bit stressful, because
yes,
when we saw the compression of the stent, it was really stressful. But in this case, maybe a cheminée should be also a good idea. A cheminée with a less aggressive valve, like Evolute Air, should be an option. It's a little bit different than my case, because my case, I had a stent and I have to deal with, it was in the aorta. So in this case, the strategy was different.
Yeah,
but it's a very, very interesting case, and I will keep in mind that we can do a kissing balloon with a TAVI valve also.
Yes, it's not exactly 50-50, but it's in 110. Any other comment on this case? That's a case which happened to John Webb in the very, very early days of TAVI, and the patient died, of course. Yeah. But now we know. Now we know.
Yeah. Alec, what is your opinion about the pacing and the left main occlusion? Is it really dangerous to do the pacing and the left main occlusion? I don't know.
No, I don't think so, because the pressure is 0, so you cannot below 0. Huh?
Yeah.
I mean,
yeah.
You can go minus. No, but I mean, well, I think you have no choice. You have to balance the risk-benefit.
Yeah.
Clearly there is a benefit, as in your case. No, I would advise to do exactly what you've done. Any special antithrombotic treatment in this patient?
Oh, nothing. No, really nothing.
No. And Jean-Philippe, you have a large experience with the self-expandable valve. Did you perform a case like that? No. Or chimney technique with Evolute or another one?
We never did provisional stenting. We usually put a wire as to secure the left main, and if we need to do it, we do it after.
That means you push your stent after, you just have your wire?
I just keep the wire inside, and if needed, I put a stent. If not, I don't do anything.
And what do you think about the technique, what we use? In our institution, we put the guide wire and the stent, but we don't perform kissing immediately. It depends of the distance, and it's probably time to time we implant the stent if we can see that it's occlusion of left main. But if it's not at anyone, we can redraw it very quietly also.
But here you are absolutely sure that it will happen. Huh?
Absolutely.
Yeah, yes.
It was a slight difference.
That was my comment as well. Yes, I was sure that this kind of difficulty will appear, because using the balloon angioplasty with a very small balloon, the left main was quite to be occluded just by balloon angioplasty, valvuloplasty.
I think that's very, very educational for the colleagues. So are you willing to wrap up?
Yes, I'd like.
Please.
The first one is I would like to speak like Hakim. The main thing during TAVI and specific analysis of CT scan, by my opinion, TAVI is done at the end of the CT scan, most of the part. Other strategies can be used then to avoid this kind of complication. We discussed about a few of them, like stenting of the ostium of the left main, the guide wire protection, catheter cannulation. We can discuss about not kissing balloon, but kissing stent inflation with or without predilatation. Other issues can be discussed, but the main thing is we have to really read the CT scan it's very important. Thank you for your attention.
Thank you. We have
Thank you, Camille.
a cardiologist to read the CT scan. Okay. Yeah.